Thank you very much. We've had exciting lectures right from the start of this program. Now let's go on to the predictive models in patients of cirrhosis who develop HCC. So we know that HCC is a common complication in patients of cirrhosis and advanced fibrosis. The incidence of HCC is rising significantly, and now with MAFLD more so. And since it's paralleling with the rise in obesity and diabetes mellitus in the young. If you look at this group, the HCC progression from simple steatosis to patients with non-alcoholic steatohepatitis, the HCC progression has been significant from 0.44 to 5.29 per 1,000 person years. And this is basically wherever there is chronic inflammation, it forms a pro-carcinogenic environment. And especially in patients with NAFLD, almost 30% of patients do not have any evidence of cirrhosis. And this is also true to some extent in patients with hepatitis C. With improved cardiac interventions, hepatic fibrosis, the longevity of these patients has increased. And since hepatic fibrosis takes almost 20 years in patients with MAFLD to form cirrhosis, we are more likely to have patients who would develop HCC in the future. So why do we need surveillance? Because we need to pick up these patients early so that you can have a curative treatment rather than pick up patients with larger HCC, which usually happens in most of our cases. And then we have lost the time for these patients to have transplantation. It is also associated with poor survival. So ideally, recommendations all over are that surveillance should be done in patients with CTP A and B cirrhotics, and in CTP C only if the liver transplantation is to be done. EASL, however, also recommends that you should do it in non-cirrhotic F3 fibrosis patients regardless of the etiology. But one has to individually assess the risk. So it has been shown that the screening strategies, and whenever you do this surveillance, it is cost effective if the annual HCC incidence is more than 0.8 per year amongst the cirrhotics. And in India, we have data in 2014 that our incidence was 0.7 to 0.8 during that time. But we all as clinicians have seen that HCC has risen significantly, and I possibly feel that it could be around 2 or even more. In non-cirrhotic HCCs, the annual incidence is 0.008 per year. So for picking up these patients of HCC in advanced cirrhosis would be in very selective population. A Chinese study over 20 years in a large number of patients showed that when you do screening, the mortality decreases by 37%, and the life expectancy in these patients also increases by more than 3 years. So ultrasound is one modality which is used for picking up these cases, but it is dependent on the operator's skills, and has a sensitivity in picking up early HCC in 53%, specificity 91%. But when you add it up with alpha-fetoprotein, sensitivity increases slightly and specificity also is not much increased. So this combination is, although most widely accepted by most of the societies, and we also in clinical practice do that, but it is not recommended as such in most of the guidelines except few. Alpha-fetoprotein L3 and PIVCA or DCP has insignificant sensitivity and usually picks up large HCC, and it is being used in only a few setups. Moreover, the implementation of these screening strategies is only in 25% even in the United States. And the implementation being very poor It is less so even in the Indian context. So, what are the predictors for development of HCC? Let's go the liver wise first. It depends on the severity of liver fibrosis. Higher the amount of fibrosis, more are the chances of development of HCC. And this has been adequately shown recently by Scott Friedman, who says that hepatic fibrosis is associated with oncogenic potential. And even more than F3 fibrosis makes an individual susceptible for the development of HCC. Increased enzyme levels. An Asian study has shown that it increases the risk of cirrhosis and HCC. Anyone with a prior decompensation is likely to develop HCC. Metabolic syndrome, especially obesity, has been found to have a strong correlation, and it's more of the visceral obesity rather than BMI increases the HCC risk of 1.5 to 4.5 fold. Similarly, increases the risk by 2 to 3 times. Dyslipidemia, especially lower HDL, also increases the chance of HCC. Old age, alcohol use and tobacco use are other risk factors which tend to increase HCC. But now there is more of talk of genetic predisposition as in other situations. We just heard about hepatic encephalopathy. Genetic predisposition, especially PNP3, LA3, which the mutations in this gene, MBOT7, again mutations in this gene, GCKR, and these TM6SF2, all of these genes have been found to have some correlation with the development of HCC. If PNP-LA3, which has been more extensively studied mutation, is associated with heterogeneous presence, then HCC risk is 2.3 times, and if there is homogeneous presence, it is increased by 5 times. So some studies have shown that there may be a role of polygenic risk scores which could predict the development of HCC. And the other authors have also mentioned about risk signatures which get upregulated or downregulated genes for predicting HCC. Gut dysbiosis, which leads to liver inflammation, is also something which is being extensively investigated now, as studies have shown that increased bacteroids and ruminaceae in patients with MAFLD have an increased chance of HCC, and increased secondary bile ducts, bile acids decrease the anti-tumor immunity. Epigenetic changes also tend to play a role. Coffee, gender differences, race and ethnicity also have a role. But we've spoken now of the non-invasive tests which have been most helpful and most validated is the FIB4, but they help you stratify these patients who are at risk of developing HCC. FIB4 is very simple to do. It takes into account platelets, AST, ALT, initially started for HCV, now being used for MAFLD as well as hepatitis B, and has been shown to be the strongest predictor of HCC and most validated. A value of less than 1.3 in the Indian context, less than 1 excludes advanced fibrosis, but anyone with a value of more than 3.25 indicates much advanced fibrosis, and these patients are likely to have HCC, as has been shown in a lot of studies. A rising FIB4 by more than 50% increases the chance of HCC as compared to a static FIB4. APRI is another parameter which we are all familiar. Its cutoffs have not been very adequately studied, but has also been shown to be of some value. Combination of APRI and FIB4 also is one of the possibilities that people have thought of. And you have a series of other predictive models like Fawn's index, LOC index, ALBI, indocyanine green retention test. serum myostatin, all have been in individual studies shown that they help in predicting HCC, but not enough validations. Elastography is also something very important, and we all are very familiar with it. Any value of more than 16.6 kilopascals, as by Bovino, has shown that it diagnoses cirrhosis, but a value of more than 30 leads to liver-related events, including HCC. MR elastography is considered to be better, but it is more expensive, time-consuming, and less available. And retrospective studies have shown that when you combine it with age and ALT, it is an excellent tool for predicting HCC. So with the help of a fibroscan, any value of more than 9.26 increases the chances. Any value of between 18 to 38 increases significantly the chance of HCC, and more so, higher the value, more are the chances of HCC. And dynamic values of fibroscan show that a 20% increase predicted development of HCC and decompensation. There are some studies now indicating that splenic stiffness more than 70 kilopascals predicted HCC, and so also LSM spleen to platelet ratio. Again, one study has shown that it is a good tool. So the problems with these scores are that cirrhosis is a heterogeneous disease which is being studied differently in different places in a diverse group of patient population. And most of these models take into account age, sex, platelet, albumin, bilirubin, and liver disease etiology and enzymes. And they have been studied to predict 5 and 10 years HCC incidence. But it is a challenge which one to incorporate into clinical practice. ALBI is one of them, which takes into account albumin and bilirubin. It predicted HCC. This was reported in 2015. AMAP, which takes into account age, gender, bilirubin, albumin, platelets. Again, in recently, Toronto HCC risk score, Lee model. All these models are existing in the literature. But the one which has gained very high popularity is the Gellard score, which takes into account gender, age, alpha-fetoprotein L3, alpha-fetoprotein, and DCP, and has been found to be sensitivity of 65% and specificity of 82%. A recent study showed that it outperformed all other predictive models in different etiologies, and a modified Gellard score has recently been published where they said that if you exclude out alpha-fetoprotein L3, which is not routinely done in most of the centers, with only age, gender, alpha-fetoprotein and DCP, a higher score would predict that HCC is likely to occur in this patient. And these are a host of other predictive models like PL-SEC, Cook score, HCC early detection, HCC risk calculators. They have been studied. Something which is not to be missed is the abbreviated MRI, and this is considered to be a very attractive alternative to ultrasound for HCC screening. It can be done in 15 to 20 minutes, being extensively used in the West, where the cost of an ultrasound and an abbreviated MRI is almost similar, has a sensitivity of 91%, specificity of 96%, and meta-analysis has shown that it is an excellent tool for picking up early HCC. The specificity is more if the lesion is more than 2 centimeters, but we need to have more validations, and probably it would be a good tool if the HCC incidence is more than 5%. So abbreviated MRI has been found to be better than ultrasound and other biomarkers, and there are some suggestions that one should do biannual ultrasound and an annual abbreviated MRI, especially in elderly and places where the HCC incidence is high. I will not go into the HBV related HCC scores because the next speaker is going to talk on that. And about these scores, with the treatment, the HCC has come down. Whether HCC surveillance is required in patients with HBV and HCV who have been treated, it would be interesting to listen to the next speakers. Artificial intelligence, as usual, is the in thing, and there are some models being developed, and personalized surveillance has also been discussed about. But this particular author mentioned to have a cost effectiveness after the treatment for surveillance. If the HCC risk is less than 0.6, less than 0.6 to 0.8, no surveillance is required. But if the HCC incidence is 2 to 3, then semi-annual ultrasound and alpha fetoprotein should be done, and possibly India comes into that region. And if the incidence is more than 3, then abbreviated MRI may have a role. And there is a study which also says that breath biomarkers is helpful in the early detection of HCC. So friends, in conclusion, I would say that HCC is increasing all over. Mast cell is the primary cause. Viral cause is decreasing with treatments. Early HCC should be picked up so that you can treat these patients. Non-invasive tests, especially FIB4 and VCTE or FibroScan is recommended, especially in the background of risk factors. Predictive models are evolving. They help to stratify these patients. Gellard is a good predictive model, but maybe not in the Indian context. ASAP, which excludes AFPL3, may be more practical in our situation. And integrating HCC surveillance into complete workup is something that is required in our setup. So thank you very much for your patient listening.